So today we'll do a quick video on rehabilitation and brachial plexus injuries. This talk was given in Trivandrum 2025 in April for the IAPMR State Conference for the Kerala chapter. It's been trimmed accordingly for YouTube. When we talk about brachial plexus injuries, we have to consider Narakas and its classification because we need nomenclature. And the nomenclature tells us how these children will improve. Roughly, we get two different categories. One is a non-surgical or a pre-surgical type, which is a very minimal injury that's not that bad. These kids usually do well, and they may or may not require a home exercise program or a therapist. Post-surgical is often a very bad lesion that will require surgery, and when they come to us, it's going to be after a surgery, and they'll need a lot of rehabilitation to achieve something. Roughly, our non-surgical is going to be Narcos 1, where 80 to 90% of these kids achieve good function, spontaneously recover in 3 to 6 months, and biceps will function within 3 months. 10% really need us, the rest might improve on their own. Narcos 2, 60 to 70% achieve good functional recovery. Spontaneous improvement is seen within 6 to 9 months. So about 30% really need rehabilitation. These kids do develop complications that require seeing a physiatrist. Narcos 3, only 50% achieve functional significant recovery, but actually all of them will require rehabilitation because they will be surgical candidates. And the last Narcos 4, where the entire nerves are completely ripped out, then we're looking at all will require rehabilitation. I think the first thing to consider is beware of mimics. We have to make sure we're not missing something else. This is the first case in the world ever described as what we thought was a bilateral brachial plexus injury. It was actually a nerve root avulsion at the spinal cord level. You can see the pseudomeningocele forming in red circles at the right side picture. And this baby underwent surgery and was quite successful for the rest of their life. But when we look at these patients, we should have clinical change indicators, exams that we can repeat to see if they're improving or not. And the active movement scale is one of those scales. It provides upper extremity movement on a scale of 0 to 7. It tests every joint and every movement. It's quite onerous, but it's a good scale. The next is the Quest scale, which is actually made for cerebral palsy, but I do use this because it helps you localize problems in particular joints and muscles quite well. Electrophysiology. So nerve conduction studies done before the age of 1 month are useless. Degeneration is happening, so you may not see the entire thing. But there are recent publications that show that the axon viability index of the axillary nerve at 1 month will predict co-activation. This is the first paper of its kind in the world ever released. When you do a nerve conduction study at 1 month, we usually find 1 of 3 findings. Either there's a normal CMAP, which is a good sign. This is not that bad of an injury. That's usually Narcos 1. A partial or a CMAP that's inelicitable, but the movement is seen. So this is going to be a Narcos 2, maybe a 3, and complications will definitely be coming. This is the kind of case that needs proper follow-up. Cases have a CMAP inelicitable with no movement, and at that point we're going to wait until 3 months. And then what we see is in 3 months, if there's no elbow flexion, the CMAP is inelicitable, we should get an MRI and plan for surgery. The NCS at 6 months, though, is where things get different. See, NCS at 3 months, no elbow flexion, surgery is the surgeon's criteria for operation. We do know that at 6 months, if you wait, 85% of biceps will improve on their own. So there is a value in delaying if the family is not willing for surgery. The goal of therapeutics. The goal is to find an aesthetic and develop an aesthetic motor engram. And what that really means is the child develops a way of using the hand the way they're expected to, like every other child. Movement that looks normal. They should then develop that movement and use it in daily life. And the next thing is the investment to get there. That cost is 10,000 repetitions with selective voluntary motor control, meaning the prerequisite for all that is they should have insight and desire to change. And these are children up until about the age of 5. They don't know. They're just going to have fun. They're going to enjoy their life, and that's it. They'll cry for milk. They'll empty their bowels and bladder, and that's it. So you can't really expect them to have insight to change. And when they develop it, then we can really start working on things. So until then, the goal is just to keep all the joints supple, watch for awareness of problems to appear, and train function when it's possible. The biggest problem we face in rehabilitation is always how this child perceives their limb. Some, in the best case, will see it as just a helper limb. It's not the best, but it does something, and that's optimal. That's okay. Another set will ignore the limb entirely. They don't use it at all. They don't like it. It's just attached to them, and that's that, you know. So we have to wait for insight to emerge where they realize their hand has a problem, that other kids can do things they can't. And when they start asking, why can't I use my hand? Then we can start training them for function. Some kids, if you look at the arm or touch the arm, they start screaming. And this is a real problem because they know there's something wrong. They don't know how to fix it. No child does. And they want to defend themselves from what they think is an attack, so they start screaming. The worst is where the arm is so deafferentated from having all the nerves ripped out, and then it just generates pain. And these children will go on biting their hand, trying to stop the pain, which is a big issue. Now, children will be children. You can't really make them do anything. And our prescription should consider that you have parents who are caught between their expectations, how the baby responds, and to physiology. Home care is the biggest thing here. It's not done by a therapist, it's not a therapy clinic, it's not a doctor, it's not a physician or a surgeon. It's what the parents do for the kids, and there's prerequisites for this. The first is that these parents should actually be mature. So when you start moving baby's arm, it's going to be a bit stiff, it's going to be a bit sore, and baby will start crying. And baby eventually learns if it cries, the movement stop. So the baby will start emotionally blackmailing the parents, trying to make them stop doing what's good for the baby. We need mature parents for this. Some people enjoy laughing at others behind their back. And from there, when it's their own child who has a problem, if everybody starts laughing at them, see, you worked so hard to make this kid know their arm is screwed up, go check for their diseases. If they can't handle social stress, doing home care is going to be very hard for them. Another thing is they have to be willing to play the long game, especially with narcotics 2s, 3s, and 4s. The 2 and 3 especially. These limbs kind of work, but then they don't work fully. They're not the best, they're not the worst. So we have to kind of stage our goals and progression and see how things develop and keep modifying our plan. Meaning, if the family thinks you're going to tell them one thing and go home and send them off and everything will be fine, it's going to be a problem. This is more of a journey than a destination. Rehabilitation of non-surgical or pre-surgical cases in the first year, the brain is present, the anterior horn cell and its axon are present. So from 0 to 3 months, the brain is looking, where did that arm go? It was there in the womb, but now it's gone. The clinical problems we face are they don't move some muscles, and they're the uninhibited pectoralis major. How do we treat this? Passive range movement prevents contractures, sensory integration via myofascial chains, and then watch for muscle action. By 4 to 6 months, things are starting to work. And what we find is, for sure, they should have a deltoid reinnervated if the axons are growing. So the brain is really looking, okay, there's a muscle, there's another muscle. I know these guys, they were there before. So the clinical problems we find are the uninhibited pectoralis major creates a lot of issues. This uninhibited pectoralis major will create an internal rotation deformity at the shoulder joint. And how do we treat this? We treat it using the prior and also limb movement training or modified constraint-induced movement therapy, which I'll describe in a bit. There's good evidence for this working, even though it's quite difficult to initiate with families. By 7 to 9 months, we really expect biceps and teres minor to be working. And if they're not, we should be looking for other kinds of problems. But these actions should be present, and now the brain is taking tally of what muscles work, what muscles don't, what they can be used for, what they're good for, what they're bad for, and it's going to find ways to make things happen. So the problems we find are pseudo-hypertrophic biceps, where the internal rotation deformity from the pectoralis major is so bad, the short head of the bicep starts to tighten up, and it pulls the elbow into a flexion, where it looks like they have a very big bicep, but actually it's just being held short by the pec major. The next thing is a possible radial head subluxation. As this thing starts to reinnervate, you might find the bicep starts pulling out the radial head from its articulation with the humerus. Co-activation again becomes a problem, and winging. Now, co-activation is where the pectoralis major latissimus dorsi prevent the arm from abducting more than 90 degrees. And again, we can predict this at 1 month NCS with the axonal nerve axon viability index. But this is when it starts to emerge. And it's important to know this because we can start looking for early and counseling families for the appropriate treatment. And then winging also starts to emerge. How do we treat this? Continuous movement therapy where you tie up the good limb for maybe 3 to 5 minutes every hour. And ask baby to do activities with their not so well working hand. Now the prerequisites for this are that the baby can actually move that damaged relatively well and do things with it. So if they have a grasp and they can do a shoulder flexion and they can take things to their mouth, that is how we do CIMT. We tie up the good arm, attach it to their trunk using a brace, and from there have them perform tasks. And they will usually scream and cry through the entire thing. They don't like this, but mature parents can make this happen. And from there, we train function, and then from there, if nothing is working, we can even use Botox. Now, this is the first study in the world to ever show that you can use constraint-induced movement therapy with Botox in these kind of patients and get very good results. We didn't know how to publish in those days, 10 years ago. So it ended up in kind of a unindexed journal. But here we have 10 to 12 months, and now the brain is kind of sad. It's seen other kids that knows what's possible, it knows it's not normal, and doesn't know what to do. Co-activation can still emerge and persist here, but now we have glenohumeral dysplasia, where the shoulder joint forms wrong because it's being held in this position all this time. How do we treat everything I've said before? And then Botox really is good. It can prevent need for surgery or less morbid surgeries. So this is where families usually fight us. They don't want the baby under anesthesia. They don't want to spend money on Botox. And those families suffer the worst because the child will need a bigger and worse surgery at some point later on. Non-surgical treatment from the age of 1 to 4. This is where the child now just finds ways to make things happen. They're going to be as creative as possible, and it might look weird, but they don't care. And the problem we have a disuse apraxia, where the brain knows there's a limb, but doesn't really know what to do with it. Insight emerges, so they know there's a problem, but they don't know how to fix it. Supination begins to develop at this age. And from there, the affected limb is ignored or made into a helper. And this is kind of how they use the arm for the rest of their life. How do we treat this? This is the first time I get a therapist involved, and it'll be an occupational therapist, because many families, as much as you teach them, they just don't get it. They're always uncomfortable. They're not sure if they're doing the right thing, as many times as you teach them. So having someone go hand over hand with this child and do tasks can really help. Occupational therapists typically tend to understand their limitations and will send back to us also. If a lot more of the therapists understood the problems that came up, I think we'd be seeing a lot more brachial plexus problems rather than just doing endless therapies and variations on therapy. Age 5 to 10, the clinical problems we face are the affected limb is used for tasks in a non-aesthetic way, and no one is happy with it. So they can use a hand, but no one likes the way the task performance looks, and everybody gets upset about it. This is where we focus on selective muscle retraining and combining with surgery if needed. Now, post-surgical cases, There's three different types of surgery. The first is nerve grafting, and what we can use is a contralateral C7, a spinal accessory to the suprascapular, etc. Typically, the indication is when there's no bicep movement 3 months with MRI evidence, and the time of operation would be 3 to 6 months. There is always this lag, and the lag is what you saw for the first year of the nerves trying to grow down to the muscles. But also, the longer you wait to operate, you have to add that much time to this delay. Meaning if it takes a year to get full innervation and you operate at 6 months, you have 18 months to re-go function from the time you operate. And this is a real problem because the brain won't really hear from those muscles until it gets innervation. So the pre-op and post-op rehab is the same, everything you saw before. But one thing I want you to tell you is early nerve surgery will lead to a normal biceps in 80% of cases. Whether you operate or not, they will always have incomplete function. Meaning, it's not the surgeon's fault, it's not the surgery fault, it's just the nature of this disease. And whatever happens, happens. But they will always need rehabilitation. So the family should not think that do a surgery and be done. It's never like that. There's nerve transfers and neurotization surgeries where you take the nerve and attach it as close to the neuromuscular junction as possible. The common procedure is Somsack, Oberlin, Doi 1 and 2. The time of operation is 6 to 9 months. The time to injure leg is 4 weeks of waiting because that's the time where you can't really use the nerve. And then the nerve will start reaching the neuromuscular junction working. If that's not happening, it's a very big concern. We should be informed. But pre-op, post-op is pretty much the same as before. The problem we find with all nerve surgeries is 33% of the axons that you transfer will do what you want them to do. They'll grow down to the neuromuscular junction and make things effective. 33% will grow backwards and become useless. 33% will join motor to sensory and become useless. So in your best case, you're gaining about half of the fascicles that you transfer to that neuromuscular junction. So you really want big nerves with a lot of fascicles to make this happen. Now, there are other muscle surgery like the mod quad surgery. And this is typically when you have very bad contractions or glenohumeral dysplasia. The time of operation is when they're in preschool. Time to injury lag is not an issue because it's a muscle surgery. So 1 month of immobilization, the cast comes off and you start strengthening all these weak muscles. There's a lot of non-therapeutic facts involved in care. Many times what we find is a family is trying to find someone to blame. They'll blame the mother, they'll blame the OBG. No one has a heart to blame the baby. But if things don't change fast, someone gets all the blame, and that's going to be mom. Now, the easiest thing for mom to do is just find a therapist and dump the kid on the therapist. It's one less thing that's her fault. After all, she has to take care of the husband, take care of the in-laws, take care of the house, take care of the baby as a whole, and then focus on the baby's arm on top of that. If things are improving as fast as everybody wants, which never really happens, then everybody starts fighting her while she's trying to do her regular stuff. The problem with this mentality is we can call therapists, we can have them do their therapies. At some point, all therapy will fail because it's not a condition due to deficiency of therapy. Meaning therapy is not the cure, it's just a path to something better if done properly. But that done properly can actually be done by the parents if they're engaged and involved in understanding. So you could give the right treatment to people who have the wrong understanding. And when that happens, baby will always cry. But then mom starts crying, dad gets angry, and they get a poor outcome. And the more expensive and invasive these modalities are, the more we expect this to happen. I think the biggest thing to understand is perspectives. Here's baby who just wants to have a good time. They don't know what the world is. They're going to live in that set. Here's parents who want baby to have the best life possible. Here is a therapist who knows exercise. We give a prescription, they follow it. Here's the problem, here's the exercise, let's do it. Here's our surgeon who knows the indications for surgery, indicate for surgery, do or don't do surgery. And then from there, once their work is over, that patient has to go somewhere. But if you give it to the therapist who knows exercise, it's still not gaining function. So you need a physiatrist, a physician who's actually going to train function. And what we see now is two different categories of care. You see, one category of care is disease-oriented. The therapists, the surgeons, they're focusing on that disease. And by focusing on the disease, what they're missing out on is the person. The other side is the family and the physician, the physiatrist, who are looking at getting the child the best function possible. So it's not to devalue anybody, but for a time, these children will require this kind of care, disease-oriented care, and at some point, the same child will require care for their entire function, and that is all these kids who actually require. There's a lot of frequently asked questions we get in clinics with patients like this. The first is, someone told us physiotherapy is enough. Is this correct? These are often families who don't want to invest too much time or effort or don't have money or don't have the resources to. So they're trying to make sure they're not doing wrong. Now, the answer really is an NCS. And the NCS is perfectly normal and everything is conducting. It's going to improve on its own. You can go to a quack, you can go to acupuncture, you can go to therapy. There's no problem. It's okay. Another question we get is, he's improving, so why should we do it anymore? Now, if the NCS is not normal, you can almost always expect co-activation of some sort. And what we're going to be looking at is then residual problems. So while the family feels that small things are changing in a good way, the bigger picture may not be, and it can lead to complications later. And this is usually a contention issue where families fight with us quite a bit. They won't let us do Botox. They won't let us do the right treatment, so they won't cooperate with critical things. And as a result, baby suffers. Someone said oil massage is good. And the answer to this is, if the arm is rusty, I mean, you put oil on it. I've never seen a rusty arm before. But here's the thing. It's a social trend where people put hot oils onto each other for fun. And the grandparents think that hot oils on the limb will be good. It's part of the traditional medicine. This is not an oil deficiency. So if it makes the grandparents and parents happy to massage the limb, do so. But then on top of that, do what's expected, the correct treatments that we teach. If the operate will be 100% success, this is often asked by an aggressive family that doesn't want to spend money, but they have to ensure that they're spending their money the right way. The answer is whether you operate or not, this child will need rehabilitation. If you operate, you have a chance of getting better function, but there is no guarantee. There is always quality rehabilitation thereafter. Is this the time for electrical therapy? Many families will know someone who knows a therapist, and the therapist will advocate for electrical therapy. This is electrocuting and shocking the muscles to make them function. Now, the correct way to do this is where your child can contract after the shock. If not, the therapist should assist the movement, and if not, it's a problem. So do it properly or don't do it. The last is our tricky case, where the family insists they're better, but they're actually worse. And in the last encounter, we had this movement, that's the response, and you refused to advise treatment at that time, so she's lost more function. How do you want to proceed? Put the ball back in their court, make them make a decision, document accordingly, because they'll come back to blame later. Economics of care. If you do proper care versus later or no care, later and no care equals a lifelong deformity. If we look at home exercise versus PT, home exercise is free versus 3 to 4,000 rupees per week and unclear outcomes because how many BPT graduates and therapists really understand brachial plexus? The cases are kind of rare, so you really want someone who's specialized in that, which we've been doing since 2009 in Amrita. Botox on time versus not. Now you could save 25,000 rupees, the cost of Botox, but you would have lifelong deformities or later surgery and more therapy. Botox on time versus late Botox means more deformity, less function. Botox versus surgery later. If they're gonna not do Botox, then it's just gonna be the cost of the surgery. And it can be a worse surgery if you don't Botox. So the thing is, it's not so straightforward. There's a young family, there's no money, there's societal pressure, there's fear. All these things come into play. The biggest question young physiatrist asks me is, if I do this, how am I better than a physiotherapist? You see, in everything in this talk, for the first year, it's me, the physiatrist, doing all the rehabilitation with these kids. I don't get the therapist involved until maybe 1 to 5 years with an occupational therapist. So this is actually a stupid question. It is just an ego issue. You do the best that you can for the patient in front of you, and this patient will help you refine your skills, and you become a better clinician, but the rest will sort itself out. If people don't know the difference between a physiatrist and a physical therapist, that's their problem. It's not yours. You make sure the patient in front of you gets the right outcomes. You see, the thing is, the colleagues that refer to us, they just want good outcomes for the cases they refer. They don't care how we do so. So if you give them that, they'll want to acknowledge you. They'll want to know what a physiatrist is, what a physiatrist does, what did you do, how did you do it. And if you pass over care to a therapist, then you lose that information, everything you've seen here. You lose patient confidence and clinical skills all in one go. The referring doctors will see you and refer and order the therapy directly because that's what they'll learn. They'll learn that you do nothing except act as a stop sign for a therapist. And this is the bottom line with these kind of cases.